Dr. Jason Falvey is a physical therapist and clinician-scientist with expertise using Medicare claims and national survey data to evaluate functional recovery, aging in place, and healthcare utilization among older adults recovering from acute hospitalization. His current work focuses on economic disparities and patient-centered outcomes, such as disability and aging in place, among older adults recovering from hospitalization. He is the second ever physical therapist to be funded by a Paul Beeson Emerging Leaders Career Development Award from the National Institute on Aging. His research on economic and social disparities in health outcomes among older adults has recently been published in high-impact journals, including JAMA Internal Medicine, and his clinical and research expertise has been featured in news outlets such as Washington Post, CNN, U.S. News, and World Reports. Dr. Falvey is a board certified as a geriatric physician, physical therapist, and still treats patients in a specialty balance and mobility clinic in the Baltimore Veterans VA Hospital. We could really use your expertise around here as well, I think. I'll let you take it away.
Well, thank you so much for that introduction. And I'm really excited to be here and talking about how to take some of this research on economic disparities and really move it into a space where it can be translated into clinical practice and really start to think about actionable ways to address the mechanisms for how poverty impacts outcomes for older adults with new disability. So you can see my Twitter handle here if you want to follow or throw up some tweets. If you're a social media user, I'm always happy to engage and talk about things during or after the talk. So as mentioned, I am currently funded by a Beeson Award and also have gotten funding to support my work from several other sources from NIH and foundation level. I don't have any other disclosures outside of that federal funding and foundation funding that was there. So, but I will tell you a little bit about me outside of the academic realm, and I always think that's helpful. And so as a lived experience, I grew up in a very high poverty neighborhood and a very high poverty household in rural Maine. And, now I have to explain to my parents, as I'm a first generation student, the academic world is somewhat new to them. So I always have to tell them, that I'm an assistant professor, and I have to use the phrase continually that I'm not an assistant to a professor. I didn't spend all that time in school. I'm actually an assistant professor, and explaining what that rank is. If any of you are first generation students, you may have also had that conversation with your parents. But growing up in Maine in a really rural area as a first generation student really gave me some ideas of how poverty impacts health outcomes. So I moved after PT school to Wyoming, where high poverty and rural PT practice were, kind of a combination for me. I was treating in some of the most rural counties of Wyoming as a home care therapist and treating people who primarily were being managed by Medicaid. And you can see one of my patients here back in my full-time clinical days was recovering from a stroke, but also had Medicaid and several economic barriers in terms of home modifications and assistive devices and accessing transportation that really opened my eyes to really what somebody with low financial resources experience in terms of recovery from a catastrophically disabling event. I then moved into Colorado to do my PhD and did that at the University of Colorado and then fellowship at Yale in epidemiology of aging to really build out how to study this in a more systematic way. And now my lab here at the University of Maryland is enhancing rehabilitation to improve community health, or the Enrich Lab really has a focus of improving community mobility and participation for older adults living with new disability. And one of the major focuses is working with older adults in disadvantaged or socioeconomically deprived communities. So we really think about mobility inequity. And I think that's an important term that will carry through is, the demands and the abilities for many of our patients after recovery or during recovery from a disabling event are very different. And often we give them very standardized rehabilitation protocols that sometimes don't accommodate well for the different demands. And we're going to talk about how those demands are different across socioeconomic classes and how really our current rehabilitation processes and even federal policies kind of reinforce socioeconomic inequities and disability. So I focus on catastrophic disability, where people have a sudden medical event. I tend to be disease agnostic, so I've studied critical illness, I've studied, orthopedic surgeries, I've studied hip fracture, I've studied traumatic brain injury, we're studying heart attack and some of the other grants, but really with a focus on, a catastrophically disabling event. How is economic circumstances impacting your recovery? So the background of my research really has a couple of key components. We think about aging in place as being alive and living at home instead of a nursing home or other facility. And for many patients, this is a really important goal. They want to be at home. There's very few patients who would rather be in a nursing home than living in another facility. But aging in place isn't necessarily stopping there. We also have to think about unrestricted participation in social activities. Can people get out and engage in their communities? Can they get out to church or social clubs? Can they visit with family and friends? And that's often not considered part of aging in place, but it's still a really important thing to make that aging in place experience high quality. Now, as a physical therapist and in my training, I got really good at thinking about what the barriers might be, and thinking about, okay, somebody's home, but they're homebound. That's not good enough. What do I need to do to help them get out and address those barriers? So we are pretty good at addressing strength and walking ability as physical therapists. I know lots of exercises. I'm pretty good at gait training. I can help people navigate a lot of the barriers that they might run into as an experienced therapist. But what we're not very good at is addressing and accommodating the economic level barriers that people experience. And this is both at an individual and a neighborhood level that impact recovery from a catastrophic disability. So when we think about why is getting outside of your house and community mobility so important, I love this concept of life space mobility to conceptualize this. And if you guys aren't familiar with the life space assessment, it's a really good way to tell how far and how frequently people are getting away from their house and how much help they need. So it helps you figure out if people are, really meaningfully re-engaging with their community. And I generally break this down into, people that can be considered community level ambulators or community level, access versus people that aren't able to get out into the community. And this is an important distinction with a lot of prognostic factors. So when we think about how poverty would affect that ability to age in place with high quality, what we know from prior work is that poverty is associated with elevated levels of disability among older adults. And we know poverty is associated with social isolation and loneliness, both of which cause low quality. And some of the biological underpinnings that have recently been elucidated using National Health and Aging Trend Study data that had some biomarkers in round 7. Some researchers over at Johns Hopkins found that, after really carefully matching financially strained older adults to their non-financially strained counterparts, that there was higher IL-6, and a really important inflammatory marker in the blood samples of people who are experiencing financial strain, and higher C-reactive protein, which is kind of a generalized marker of inflammation. But these together show that long-standing exposure to poverty and financial strain can have a biological effect. And that might be one reason why people that are living in poverty are substantially more likely to experience disability. So this, kind of old paper from New England Journal of Medicine really showed the elevated risk of disability among people that were living, at the lower ends of the poverty. So people that were making below the poverty line, or really even up to 199% of the poverty line, were experiencing significantly elevated rates of disability and functional limitations. And even among older groups where disability was more common amongst everybody, there was still 1.5 to 2-fold higher risk of experiencing a disability for people living below the poverty line. So we know that poverty is a really powerful antecedent to experiencing disability. And work that was recently published in the Journal of the American Geriatric Society, looked at how poverty was associated with different trajectories of loneliness during the COVID-19 pandemic. And one of the biggest differentiators between these different trajectories of loneliness symptoms that people experienced were being in poverty. So people that were living in poverty were 2.5 times the odds of being in this persistently lonely subgroup, where they consistently, during the pandemic, felt like they were not able, had that subjective feeling of loneliness and weren't able to engage with peers in a meaningful way. So poverty was a big driver of who was in those categories versus the other ones. And when we think about policies that are in place to address intersections of poverty and disability and try to mitigate some of those effects, they're really wholly inadequate. And there was just a story yesterday in NPR that Kaiser Health News put out that looked at this escalating rent crisis, which I'm sure is happening in Chicago. It certainly is happening around the DC and Baltimore metro area, where even inflation-adjusted disability payments are not keeping up with rent payments, and so people that are disabled and might not have other avenues to bridge some of those financial gaps are being left homeless or in really much less stable housing situations, which certainly is not a situation that's going to help mitigate any of their health concerns. So there's a lot of connections between poverty and disability. And we might think, well, older adults with catastrophic disability, do they really want to get out and do stuff in the community? Like maybe they just want to be at home. But the research says otherwise. The research says that the activities that are considered the favorite activities for older adults in the community are resoundingly active. People want to be able to walk and jog outside, or work on their tractor, or do outdoor maintenance, or go out and play sports, throwing a ball around with their grandkids. These are pretty active tasks. They're not playing mahjong in the retirement home. So we really have to think about, are our restorative care activities aligned with what the older adults really want to be doing. When we think about community mobility demands of older adults have to walk several hundreds of meters sometimes to attend these important social and recreational tasks. Getting to a doctor, can take up to 64 meters of walking. Getting in and out of a pharmacy, especially if it's Walmart or Target, can be 200, 300 meters. Hospital visitation, and for those of you who work in large hospital systems, it probably doesn't surprise you that you could be walking several hundred meters to get from a parking lot into a patient room in a large medical center. And that's all well and good, except for most of our rehabilitation goals for older adults. When we tell them that they've maxed out the ambulation scales or they're doing really good, cap out at 150 feet. So when somebody walks 150 feet, they can score the maximal FIM score in inpatient rehab in some cases. They generally are considered pretty high level for a skilled nursing facility, and that would be a precursor for discharge from a home healthcare facility. So often our rehabilitation benchmarks are even a little bit too low. When we think about community mobility, if we fail to help people recover in their community mobility, we're probably putting them at risk for further social isolation. So work that we're doing in the National Health and Aging Trend Study, some of our preliminary data suggests that there's 1 in 4 older adults who can't walk 3 blocks outside. And those who can't have more than double the likelihood of reporting social isolation. So community mobility is an important antecedent to being able to meaningfully communicate and collaborate with your peers, your family, your friends, and make those social connections. when we think about who loses community mobility, so what are the things that would make somebody vulnerable to losing community mobility? People that have restricted activity, people that are sick or ill, have some COVID-related symptoms and have been laid up in bed for a couple of weeks. The community mobility loss, the likelihood of community mobility loss increases 144%. And a hospitalization is even a more powerful predictor of who's going to lose community mobility. 621% likelihood increase of having a community mobility loss. And that's really, makes me think that we don't do a great job helping people restore community ambulation after acute admissions. And the question is, why is that? And who is it disproportionately affecting? When we think about the effects of a hospitalization, we really consider it conceptually as a restriction or a shrinking of life space for older adults. And that's associated with decreases in quality of life and increases their risk of being homebound or becoming nursing home dependent in the near future. And what's really important to remember is that this disproportionately harms socioeconomically disadvantaged older adults. And we're going to walk through why that is and why there's so much urgency on improving community mobility and this high quality aging in place as part of our rehabilitation processes. So we're going to walk through both the impacts of poverty on aging in place in terms of number of days spent at home, and then we're going to talk about the impacts of poverty on participation and put those together at the end and really think about how we're going to conceptualize potential interventions. So there's some ideas that low-income older adults maybe don't need to, don't want to do as many things, but they actually have higher demands for community mobility, but worse outcomes. And that's related to living in lower quality built environments, having lower access to high quality healthcare, and transportation access, which we don't talk about a lot from a medical standpoint, but certainly something that I think is important, and we'll share a little bit of work from our group that talks about the impacts of living in low-income communities and how that impacts transportation access. So if we think about our conceptual model and these pieces, we're going to really focus on what's the impact of poverty on these number of days people are spending at home after a catastrophically disabling event. And so we've done some work in our lab using claims data, examining how poverty impacts this. And we use a metric called days at home as a foundational patient-centered outcome. So for those of you who aren't familiar, days at home is important conceptually because most patients, we wouldn't argue that most of them want to be at home versus in a healthcare facility. There is some validation work that showed that more days at home is associated with higher levels of function and higher quality of life. And it's really valuable because it allows us to get an idea of what their baseline pre-injury function was. And using days at home measures in claims is particularly valuable for traumatic injuries like a hip fracture or traumatic brain injury, where we might not get great pre-operative information from somebody who's experiencing delirium or high pain or had to go immediately into emergency surgery. So this helps us be able to identify what risk people might have for poor post-operative recovery and what's driving some of those differences. So claims-based days at home is also being considered as a quality measure by some organizations. So I know CMS has looked at it in terms and some of their more bundled payment models. They've looked at it in terms of a population health measure for looking at ACOs. National Quality Forum, I know, is evaluating measures related to days at home. And work that was recently published in Annals of Surgery, which literally I saw today, an hour before the talk today, we actually have a publication in Annals of Surgery that looks to show that days at home is a really important measure of hospital quality that measures something different than measures like readmissions or mortality for trauma centers. So it's an important outcome that I think is gaining some traction. So what we do to calculate this is we use Medicare hospital and SNF files. We can identify every day that somebody spends in a hospital, an inpatient rehab, or a skilled nursing facility. And we can also use MDS files, which are the nursing home assessment files, to identify how many days people were spending in long-term care. So we can really granularly capture what community dwelling older adults were experiencing in terms of their health before and after a hip fracture. We also use the outpatient files, which is a new assessment that's been added in some more recent measures of days at home, where we pull out emergency department days and hospital observation days, which are days that people are generally not spending fully at home and reflect a lower health status. And there are some measures, and we're doing this with some of our newer work, that we even subtract out days that people are at home but receiving home healthcare services, where we know from statutory requirements that those people are homebound. So that all comes from some additional work that's been done by several researchers to really try to conceptualize what does days at home mean to patients. So there are some people who just look at days alive and out of the hospital. Some groups, including mine, are looking more at these, how do we separate out high quality? And is that telling us something different? So when we think about how we've used this data, we've actually gone ahead and say, how does poverty impact the pre-admission function of older adults? How is that influencing what's going on? And are those pre-admission trajectories of what's happening predictive of what's going to happen to that patient afterwards? So I use these Medicare claims to identify hip fracture survivors and created monthly files. A monthly file with a count of days at home every month for 6 months before the fracture and 12 months after. And we use latent trajectory analysis to look at unique pre-admission patterns of function to see what's driving those patterns. And then we use multinomial regression to predict how those trajectories were going to identify, later recovery. We also limited the sample to people with ADRD because, from clinical standpoint, this population tends to be really challenging to predict outcomes for. So when we look at all hip fracture survivors, people with dementia typically do worse, but we wanted to see whether or not in a sample that already had a geriatric vulnerability, could poverty help differentiate what was happening to them before the fracture, and was that meaningful to identify post-operative risk? And we really believe that this could help with risk stratification or identify pre-admission functional status for those who can't provide that kind of information. Medicare already has measures of claims that can be provided to hospitals in terms of number of hospital days that have already been paid for. Home healthcare agencies can identify whether or not patients have other active care episodes going on. So there would be ways to feed forward this information automatically into electronic medical records that could potentially be informative for risk stratification. So when we went ahead and modeled these pre-operative trajectories, what you're seeing on the screen is, our latent trajectory analysis identified 3 subgroups of patients. And one subgroup, which was the largest one, generally spent most of their days at home. So about 90%, the 6 months prior to hip fracture with patients with dementia did pretty well, and they were spending most of their time at home. And then there was a group that was pretty actively declining, about 5% were actively declining prior to their hip fracture. And another group seemed to be either recovering from another prior event, but was spending on average quite a few less days at home, but on a more favorable upward trajectory prior to their fracture. So we went ahead and said, what patient characteristics are driving differences between these trajectories? And what we thought was, okay, maybe this is just reflecting like age. We know that hip fractures occur more in the oldest age groups, and maybe the red line is just identifying the oldest old. But what we found is that that really wasn't the case. The youngest group was actually the group that was doing the most poorly. So that was interesting to us and told us that we're measuring some sort of unique vulnerability here. We went ahead and looked at comorbidities using the Elixir score, which is a nice claims-based way to capture a multimorbidity. And again, there was some subtle differences between the groups, but nothing that was really striking us that there was like 2, 3, 4 additional comorbidities in that really poorly functioning group. But what we really saw was Medicaid dual eligibility, a good reflection of poverty, was substantially higher, 50% higher rates, from 20 to 33% in one of the groups and from 20 to 29% in the other group. So 50% higher rates, relatively of Medicaid eligibility. And that was, striking to us and saying that, okay, poverty is definitely driving some of these pre-operative trajectories. And then when we said, what does this mean in terms of outcomes? The 1-year mortality rates, for each pre-operative trajectory, we could see a pretty significant mortality gradient going from 21% for the most favorable trajectory pre-admission to 32% for the least favorable trajectory. So we're identifying a unique subgroup of people that's medically complex with high poverty, but they're younger. So it's not your traditional risk prediction models, and these latent trajectories help us kind of identify maybe some hidden groups that are not doing as well prior to the fracture and help prognosticate outcomes. When we look at the post-operative trajectories, there's a little bit more heterogeneity, but there's clearly some groups who do really well, like these blue and black groups that tend to get back to spending quite a few days at home. And then this red group on the bottom spends substantially less time at home. And even though only 5% of the people were in that declining trajectory prior to admission, 40% of the membership of that group ends up in this really poor preoperative trajectory. So it's telling us that we're identifying, using poverty and other metrics, drivers of poor outcomes after hip fracture for a population of people with dementia that might otherwise be difficult to prognosticate because there's so many other factors. And doing this all in claims is really important because it means that if we have patients that are experiencing traumatic injuries and we don't have any caregiver information, or we don't have other social or economic information, just information in claims can help us identify who might need additional resources in that post-operative period. So then we decided to do something similar where we would really look and see what is the additive, multiplicative effect of poverty and ADRD together, not the latent trajectories. We wanted to do something a little bit more methodologically systematic to go through and say, okay, we know that dementia-related disparities and outcomes are not great. Is that gap wider for people that are living below the poverty line? And then could poverty be a mechanism for why people with dementia do more poorly after a hip fracture? So we used a similar data setup and used some weighted generalized estimating equations, which allows us to account for probability of death every month. So instead of having to impute data, we can weight each observation based on the probability of death in any given month. So help control for that bias. And we adjusted for the standard factors to isolate medical complexity, fracture repair, and other really important both individual level and community and hospital level factors. What we found was really interesting. So for people that didn't have any poverty, so they were living above the poverty line, they weren't eligible for Medicaid. If you can see, people with dementia after a fracture, you can see, they have a pretty big decline during the index fracture month. And then you can watch the recovery process. And people with dementia have a slower and less complete recovery. Not surprising to any of us who work in this population. But then you look at the widening gap for people that live below the poverty line. So the lines shift down, but the gap between this group and this group is substantially wider. And so people that are living below the poverty line have greater disparities related to dementia. So that tells us poverty is driving some of these dementia-related disparities. And it's in an intersectional way. It's multiplicatively worse to have dementia and be living below the poverty line, because you might need a lot more resources for caregiving or for equipment, but you're less able to meet those demands. If we put this in another way, for those living above the poverty line, the dementia-related disparity is 44 more days in a hospital or nursing home, right? That resonates with patients, that you're going to spend 44 more days in a nursing home. If you're living below the poverty line, that goes to 58 more days. So we liken that to a poverty penalty of 14 days. You're spending 14 fewer days at home if you have dementia, just because of the impact of poverty. That exacerbates the impact of dementia above and beyond what you would expect. So this is just the estimate for people with, the dementia estimate in the model. There's still an entire, Medicaid estimate in the model as well. So it's just saying that if you have dementia and poverty together, the impact of dementia is 14 additional days if you have them both together. So that interaction is really significant and really compelling. So what are the mechanisms? Unable to access needed supports. So we think about durable medical equipment or home modifications that might be more necessary to keep somebody that has dementia safe at home. Transportation barriers, people that may not have access to transportation or may have previously relied on public transit and now cannot because of mobility related issues. Things like food insecurity or inability to tap into supplemental paid caregiving may all influence how poverty drives fewer days at home after a hip fracture. And even the perception of poverty can be really powerful driver of outcomes. So Medicaid dual eligibility is generally means tested of some ways. You have to prove, in some states, you have to jump through a lot more hoops than others to prove that you're low income and don't have assets and resources to pay for care. But even the perception of being poor can drive poorer outcomes. So work that we published in JAMA Internal Medicine earlier this year showed that people that just perceived that they didn't have enough monthly income to meet their needs had substantially higher rates of mortality after experiencing a myocardial infarction. So this is a paper that was done with colleagues at Yale that really just looked at one question asked at hospital admission: what was your financial situation? Did you have enough money to make ends meet every month? People that said that they had not enough had more than 70% increase in the odds of mortality over 1 year in the adjusted models. So even a perceived lack of financial resources definitely drives poor outcomes. And then beyond individual level poverty, we have to think about the fact that lower income patients are also more likely to live in lower income neighborhoods. And those neighborhoods have additional barriers to community mobility recovery and high quality aging in place that disproportionately impact patients with low incomes. So we think about these three domains: transit access, built environment quality, and access to healthcare. And those all influence unrestricted participation in social activities. So we know people in poverty from our prior work are spending fewer days at home, but are those days lower quality? Are they less able to return to these social activities? Let's start with transit access, and we'll share some of our work and talk about how that impacts people with poverty. In urban areas, so Chicago is one, and a lot of the work that was done on some of this was done actually in Chicago, but up to 20% of older adults in urban areas have to walk more than 500 meters to access fixed route public transit. More transit stops in neighborhoods are associated with better mobility. So public transit infrastructure does influence how people can walk around outside. But what we see if we think about the Baltimore area, the places that have the lowest transit density in red are also the places that rely the most on public transportation. So people that rely on it the most in the low income area of Baltimore are walking the furthest to get there, or they have the least number of stops. That's not uncommon for many urban areas. In Baltimore, this also coincides with the most economically deprived neighborhoods. So low socioeconomic status, low availability of transit, but high reliance on transit to get places, which means that the demands for getting around are much higher. In work that we recently just published in Journal of American Geriatric Society, we found there were several factors associated with recent public transit use among older adults in the National Health and Aging Trend Study. But one of the biggest barriers was living in neighborhoods with broken or cracked sidewalks near your home, which was associated with substantially less access to public transit. Even though people with financial strain were trying to rely on transit more, if they lived in these broken and disadvantaged neighborhoods, that was particularly a large barrier for them to access public transportation. 10% of older adults in the US overall use public transportation, and many of them for their regular doctor. So this is not a small problem. And then we think about paratransit or other services that are often used to bridge gaps for people with low incomes or living with disability. And some of the qualitative work that we're doing in our lab is suggesting that people are really only able to rely on these services for necessary medical appointments. And there's so many barriers to using it and so many delays in the service that using it for social engagements becomes problematic. Patients that we've interviewed have said they put Lyft and Uber on their phone as a backup, but those are people that have financial resources to pay for those rides, the $20 or $30 it would take to go from one side of Baltimore to the other. So this tells us that even supports that are in place to try to help bridge some of these gaps are really not adequate to address the needs of people with new disability that also are socioeconomically disadvantaged. Poor transit access also contributes to social isolation and loneliness. When you have transportation barriers, you're more likely to report participation barriers. And many of the patients in our qualitative work have really endorsed that when there's transit delays and inability to meaningfully participate socially, then they experience more psychosocial distress. And when you have social isolation, it's that comes from poor transit access or from other other mechanisms that drive increases in social isolation. That contributes further to more disability development. So it's a vicious cycle. So work that we published in JAMA Internal Medicine really looked at as people increase their social isolation on a 0 through 6 scale that we use that had been validated out of NHAT's work. We found both higher levels of disability pre-admission and greater gaps between pre and post ICU admission. So we were seeing that social isolation was driving higher disability development after critical illness hospitalizations, another catastrophically disabling event. So the implications of not getting people out into the community and increasing their social isolation might mean increased vulnerability to disability or even death. And in the same paper, we found that as people had increasing social isolation from 0 to 6, their survival probability over the next year was substantially lower in a very, in a very gradated way, which ended up being double the risk of death between the most and least socially isolated. So this is another really important reason that getting people participating and improving social function is so critical. It's not just about affective domains for patients. There's real physical consequences that come from a failure to regain participation in social activities. So then we think about built environment quality as a second domain and a barrier to community mobility. And in Baltimore, this photo taken in Baltimore sidewalks, you can pretty apparently see that somebody walking with a walker or a cane and a mobility deficit would struggle mightily to get around in this neighborhood with switching surfaces from concrete into mud, blocked off sidewalks requiring people to cross multiple times or walk on these uneven and broken sidewalks. If you live in a neighborhood like this, you're statistically 4.5 times more likely to have a mobility disability, the inability to walk 2 or 3 blocks. And that particularly impacts people that have a pre-existing functional limitations. So even healthy older adults are going to be less likely to be able to move around in these neighborhoods. But if you're living with another disability, that substantially increases your likelihood of having mobility-related issues. And not surprising. If you don't have continuous sidewalks, like in this picture, where you have several breakups of the concrete, you have blocked off areas, you have uneven surfaces, you're also more likely to be a recurrent faller. So that was work done out of Johns Hopkins with the National Health and Aging Trends Study. So community environments really do drive mobility behaviors. And even just my walk to campus, I see holes in the sidewalk frequently that somebody with a cane or a walker, if they put their cane down into one of these holes, it would be very, very difficult for them to maintain their balance. And it may be a reason that people avoid going outside. These neighborhoods are much more common. These deficits are much more common in lower income neighborhoods, which have less tax revenue coming in. Sometimes they are focused on less at the city level. And there's a lot of structural, racism level issues and state and federal level policies that have systematically reduced resources to these neighborhoods over the past 100 years. And then access to healthcare in disadvantaged communities is also lower, not just in terms of volume of providers, but also volume to high quality providers. If you live in a high poverty zip code, you're going to be receiving lower quality skilled nursing facility care. And if you are being treated by a home healthcare agency, that home healthcare agency treats a high percentage of low income patients, they tend to be lower quality, and the readmission rates and patient outcomes that they get typically are lower. And that's independent of some of the patient characteristics. So there's a thought that lower quality facilities are going to be more likely to be located in low income areas. Work that we've done recently with my colleague at NYU, Jasmine Travers, who's a geriatric nurse practitioner, that was funded by the Donahue Foundation, really reinforced the fact that lower income neighborhoods are more poorly staffed. We found that if you look at the relative difference in staffing between the most disadvantaged neighborhoods, the highest poverty neighborhoods with the poorest housing, as compared to the more advantaged facilities, we were seeing substantial disparities in registered nurse and CNA staffing, as well as all of the rehabilitation disciplines, with a relative shift towards using licensed practical nurses who have lesser qualifications in many states than a registered nurse, which all serve to disadvantage patients that are receiving care in these facilities and may leave them with some unmet needs. And work that we've done with critical illness reinforces the fact that living in one of these low-income neighborhoods is associated with poorer recovery. So we found that people in these low-income neighborhoods, the most disadvantaged, the highest 25% of poverty, had pretty significantly elevated rates of disability over the year following ICU discharge. And that really started to widen after the post-acute care period had ended. So when people were getting formal home and skilled nursing facility care, there was a little bit less difference in disability rates, which happens about the first 100 days of post-discharge care. And then we really started to see a widening of the most disadvantaged and the least disadvantaged patients. And this was in a sample of critically ill patients who were living in Connecticut as part of the precipitating event study led by Dr. Tom Gill. overall, when we did the average counts, it was about 10 or 15% higher disability burden over 1 year for people living in the most disadvantaged neighborhoods. So we really take all of this data. I really think about this as, as a reason that we need to move towards mobility equity. Socioeconomically disadvantaged patients have higher demands for community mobility, but often receive the same amount of care, have the same rehabilitation goals, they're held to the same standards, and there's policies that are not often flexible to allow us to help accommodate those needs very well, which means that we're widening income-related disparities in mobility through how we typically approach post-hospitalization care. In acute care and rehabilitation settings, we rarely are afforded the opportunity to move patients outside and do outdoor ambulation or minimize practice navigating environmental hazards. There are rehabilitation facilities that are exceptional that do a good job with this, but the average rehabilitation facility doesn't do this well. Many functional outcome tools in rehab, like we mentioned, max out at 150 feet. And rehab, like we mentioned, is also not as available in facilities in high poverty areas, which means that people that are receiving care in those areas may go without a higher, either receive a lower volume of therapy or receive lower quality or both. In home health care, there's a homebound requirement for older adults. So that leads to, both artificial and real barriers to practice community mobility with patients. Many home care agencies won't allow it because Medicare might not consider that patient to be homebound. For a wealthy patient who doesn't have to walk several blocks to the bus stop, that's not as big of a deal. But for somebody who lives in a lower income neighborhood who has to be able to get onto a public bus after walking 4 blocks, not being able to practice that with a skilled therapist could really lead to them not feeling safe doing it on their own, and for them to forego that. And without backup options like Lyft, Uber, taxis, or having people that own cars to bring them to appointments, it may lead to some transportation disadvantage or other unmet needs. And even if you discharge somebody from home care with the expectation that you make a referral to outpatient care, getting to outpatient care 2 or 3 times a day or 2 or 3 times a week is very challenging. It requires consistent transportation. At my hospital, it's $10 to park at the rehabilitation facility at Camden Yards to do an outpatient visit. So 2 or 3 times a week would be financially unfeasible for many patients living below the poverty line. And outpatient care similarly doesn't focus on community mobility, public transport access, or other barriers like walking over uneven sidewalks or cracked curbs. Because patients are being seen, sometimes multiple patients being seen at a time. So it doesn't really allow for optimal return of community mobility function. And if you want to prescribe somebody durable medical equipment to allow them to help bridge some of those gaps, Medicare explicitly only allows medical devices to be prescribed if they're needed for use in the home. So if a patient needs a device to get around their community environment, but they don't need it to get around their home, they're not allowed to receive that under a Medicare payment. So the device I think of is a rolling walker, which often is a 4-wheeled walker with a seat, really helps people navigate outdoor environments, helps accommodate some mobility limitations and endurance limitations. But if that person doesn't have a need for that device in their home, Medicare won't cover it just for community use, which I think disproportionately disadvantages lower income populations who can't go out and buy it themselves. So how are we approaching addressing these neighborhood barriers? And my K Award project really thinks about how to look at these factors, the influence of neighborhood disadvantage using data on this high quality aging in place. And we're filtering it through community stakeholders like paratransit users and other people experiencing disability and mobility limitations, and trying to create a structure where we can treat patients that address both supplemental rehab for community mobility, but also tie in municipal level interventions like getting access to other paratransit services and addressing food insecurity and using community peers to help navigate some of the community specific barriers to mobility people experience. So this is where my research is going, is how do we take what we've learned about economic limitations to community mobility and really implement it into practice. And the overall goal of this work is, can we get people's life-based mobility better, either through restoring function or helping get compensations to allow them to fully participate. And then the last thing I'll say is this work also has some policy relevance. The policy targets we would really want to advocate for is, I think the really easy low-hanging fruit is we should shore up safety net supports for patients to reduce the burden of poverty on healthcare outcomes. But other more targeted solutions might be thinking about how to take these deprived geographic areas at census block group levels or census tracts and be able to micro-target funding, enhancing reimbursement to facilities that are treating in these deeply deprived areas. And that might be a solution to help reduce some of these healthcare disparities in a really focused way. And then something simple about durable medical equipment policy to allow community level prescriptions of devices that patients need to access the community and prioritize community mobility as an aspect of health and not just a bonus for people to be able to return to after experiencing a catastrophic event. So I think the take-home points are that individual and neighborhood poverty drive poorer outcomes in an intersectional manner with a lot of geriatric vulnerabilities. But our restorative care processes right now don't really account for the elevated mobility needs of high poverty individuals. And there's a lot of structural issues related to federal and state level policies that impact recovery of community mobility among low-income older adults. So we really need to think about how we address both functional impairments and contextual factors to really maximally be effective in addressing these concerns. So I know that was a lot of information. Go right up to the limit here. Got 5 or 6 minutes, I know, for questions, but I'd be really excited to hear what questions you have or about the approaches or other directions that the lab is going. And again, thank you for sitting and listening for an hour here.
Thank you so much. I think Sarah, Dr. Bradley had to step off possibly because I know she's got to have a clinical load, but yeah, that's your work is amazing. Thank you so much for hearing about this. I'll just sit in real quickly to help moderate, but any questions, please. You gave us a lot. Is it Dr. Mercury?
Yes, thank you. Very good talk. Thank you so much. I think one of the things it underscores is really emphasizing the relationship of morbidity and mortality to loneliness, which I think a lot of our colleagues don't look at front and center, unfortunately, with patients. And I wanted to make one comment. Part of my population that I work with is rural. And so mobility becomes a huge issue when I'm doing, for example, instrumental activities of daily living, and I ask them about transportation, and I ask the public transportation question, they go, what public transportation? So I think that's another area with where poverty will have a big effect. But thank you, great talk.
Yeah, thank you. Growing up in a rural area, I certainly was not exposed to public transit until I moved to Denver very late in my adult life.
Jason Salen Heinemann, thank you for a wonderful presentation. It underscores how important social determinants of health are. And as somebody who grew up in a town of 3,000 in rural Eastern Washington State without any transportation system, I certainly can appreciate that family and friends, church organizations, volunteers are critical to older adults' well-being in less resourced areas than major cities. So thanks so much. Appreciate it.
Yeah, great. Thank you, Dr. Heinemann.
Any other questions? You're doing a lot of what you're trying to accomplish, especially when you get to the policy level, it feels like you're tackling some of the things that a lot of times we feel are not as potentially modifiable and just harder to turn. So like it may be a longer push and press, but it's extremely needed and you know, to get to the long-term outcomes that we're looking for. Any other questions? Oh, Dr. Mercury.
I think this also, your talk also underscores the need for health systems, large health systems like ours, to really be socially conscious, to address these needs in the community as part of our health approach. And hopefully if enough health systems, large health systems do that, maybe we can affect policy change.
Mm-hmm.
Yeah, I think, you know, if I'd had another bit of time, I think that would have been a really important factor to talk about. Is there are health systems that are addressing housing and poverty level issues for patients and recognizing that it does reduce healthcare costs and improve outcomes in an effective way. You know, they're targeting their high utilizers as kind of a, you know, a self-serving way to address poverty, but they're recognizing that there's more they can do in their communities to improve health. And I know our health system is really focused on partnerships in West Baltimore communities for those reasons.
We have one clinic that's using health coaches. And so they're trying to not only help the person with the appointment, but also trying to help how are they going to get to the appointment and so on. And I think it's a small step, but it's a step in the right direction.
Wonderful. Any last question before we wrap up? You may be hearing from a few, I know of our colleagues through the Pepper Center and elsewhere that I know I've gotten notes about your talk, because it definitely hits and actually a few that were not able to make it today, that where your work is just really is very complimentary and your expertise would be well sought. So thank you so much for agreeing to talk to us today. It was a fantastic talk. And again, thank you so much.
Yeah, great. Thank you guys for having me so much, and look forward to hearing, you know, via email. Feel free to reach out if other questions come up. I would love to hear from you.
If you have 1 more minute or 30 seconds, we have a question. Debbie, would you have a quick question? I think you're on mute. I saw the hand go up, but maybe that was an error. Also happy to connect you to Dr. Falvey as well, if you'd be responsive to questions that might follow the presentation. But again, we're at time, but thank you so much.
Yes, thank you guys.
Have a great Friday and weekend.